Hello guys and welcome to our third video in our drug-drug interaction. And as previously discussed, di ba magpo-form ng complex or mag-chelate yung ilan sa mga antibiotics natin with divalent or trivalent cations. So we are going to discuss complexation, and I will tell you this is one of the most easiest to remember, and this is one of the most easiest interaction that you will explain to your patients. So let's start. Our first drug is tetracycline plus antacids. Antacids containing aluminum, magnesium, and calcium. So what will happen? Tetracycline have a high affinity to form chelates with polyvalent metallic cations such as ferric, ferrous, aluminum, magnesium, and calcium. Many of these tetracycline metal complexes are either insoluble or otherwise poorly absorbable from the gastrointestinal tracts. So milk and other dairy products containing with antacid, polyvalent cations, as well as various iron salts ingested simultaneously with tetracycline derivatives will also decrease the absorption of tetracycline. So technically, 50% to 90% ang marireduce absorption ni tetracycline. What are we going to consider is to have a dosing interval of 2 to 3 hours before taking antacids, after taking tetracycline, or antacid muna, tapos tetracycline. Basta't magkahiwalay itong dalawa within 2 to 3 hours, it will prevent the interaction of the both of them. Next, quinolones plus antacids containing, again, aluminum, magnesium, and calcium. An interval also of 3 hours between the ingestion of quinolones and cations prevents this interaction. What is going to be the result if ever it will be taken together? It will result in the formation of poorly soluble chelates, resulting in reduced antibacterial absorption. Also, it will decrease the antacid effect kasi nga, ang antacid natin na nagko-contain ng aluminum, magnesium, or calcium, magbabind siya with quinolones, so it will not render its effect. Therefore, pareho silang bababa ang effect. So, again, an interval of 3 hours between ingestion of quinolones and antacid containing this type of cations is needed to prevent the interaction. Next, penicillamine plus antacids. Same with the two types of antibiotic that we already discussed. It will also form less soluble penicillamine chelates, resulting in reduced absorption of penicillamine as well as decreased antacid effect. So again, 2 to 3 hours interval before taking penicillamine and antacids. Next, OFLOXACIN plus multivitamins. As we all know, multivitamins contains divalent or trivalent cations, so nagkukos din ito ng interaction sa mga quinolones, like yung OFLOXACIN. Ang mga multivitamins natin, like Centrum, it contains zinc, ferrous, calcium, magnesium. So itong mga to, categorized di ba sila as divalent or trivalent cations, so it will form complexes or chelates. 2 to 3 hours ang dapat na pagitan nila. And if ever hindi ito naiwasan, ang magiging result, magkakaroon tayo ng decreased antibacterial effect and also decreased multivitamins effect. Lastly, tetracyclines or quinolones plus dairy products. As we all know, dairy products contain calcium. So calcium will form, or tetracycline plus calcium forms chelates and complexes that are not going to be absorbed by the body. Same action na parang katulad dun sa mga diniscuss natin previously. So what you are going to advise the patient is to refrain or do not simultaneously take these medications with milk. So para maging safe, sabihin nyo sa mga patient ninyo na kapag umiinom sila ng antibiotic, either palipasin nila ng 2 to 3 hours before sila uminom ng gatas or kumain ng any dairy products, because separating the dosage by 2 to 3 hours goes some way towards reducing the effect of this type of interaction. Ano pa ang pinaka-crucial na dapat natin dandaan? sa mga complexation reactions na to. Ang complexation kasi, it involves antibiotics. So alam naman natin na kapag na-decrease ang absorption ng antibiotics natin, bababa ang plasma level nila sa katawan natin, therefore mataas ang possibility na magkakaroon ng drug resistance ang ating mga microbes or mga bacteria. So once na nagkaroon na ng drug resistance, once na tinake nila ulit itong antibiotic na to, it will no longer be affected. So mag-shift na sila sa mas malakas na antibiotic. Therefore, mas toxic yun sa kidneys natin or sa liver natin. Also, mas mahal siya. So you as a pharmacist, you need to carefully and you need to vigilantly discuss this to your patients para maiwasan din ang ating drug resistance. So tapos na tayo sa complexation. As I have told you, madali lang ang complexation. Antibiotics plus divalent or trivalent cations. Mabubuhay na kayo dahil ang result lang nun pag pinagsabay complexes that are unabsorbable by the body and the chelates. Now, we are moving forward with alteration of GI flora. In our GI tract, there are bacteria, fungi, and other small living organisms residing to it. So, alteration of GI flora may cause interactions, especially with drug-drug interactions. Pwede rin siya mag-cause with drug food, pero magfo-focus muna tayo sa drug-drug interaction. So, erythromycin plus digoxin. Erythromycin acts by inhibiting the protein synthesis, which is binding to the 23S ribosomal RNA molecule in the 50S subunit of ribosomes in susceptible bacterial organisms. Also, erythromycin is bacteriostatic. Pag sinabi natin bacteriostatic, piniprevent niya lang yung growth ng bacteria. Digoxin or lanopsin has an inotropic effect. And digoxin is metabolized by the bacteria in the small intestine. So, ang metabolism ng digoxin, walang kinalaman si cytochrome P450 system sa metabolism ng digoxin, technically. Ang nagme-metabolize sa kanila yung bacteria sa ating GI tract. So meaning, kapag uminom ka ng digoxin, huwag kang iinom ng erythromycin agad. Why? Kasi si erythromycin, malakas ang possibility na patayin niya yung mga bacteria sa GI flora natin. Eh si digoxin nga, di ba? As I have mentioned earlier, na may metabolize siya through GI flora or ang mga bacteria sa GI tract natin. Now, if erythromycin already killed the bacteria in our GI tract, then metabolism of digoxin will be lesser. Therefore, it will increase the inotropic effect of digoxin. As mentioned earlier, the result, if pinagsabay mo yung erythromycin and digoxin, it will decrease the metabolism of digoxin and it will also increase the absorption of digoxin since hindi nga siya na-metabolize. Hyperkalemia and negative inotropy also rises pag hindi na-metabolize si digoxin. Now, we will further discuss hyperkalemia and negative inotropy. So, digoxin acts on inhibiting sodium-potassium ATPase. Di ba yun naman talaga ang mechanism of action ng ating digoxin? So, look at this picture. This is your sodium-potassium ATPase with sodium and calcium exchanger. So, normally, the sodium-potassium ATPase pump causes sodium to leave the cell and potassium to enter the cell. So ito, si sodium, in normal physiology, lalabas siya, tapos si potassium, papasok siya. Now, ang digoxin, pag nag-act siya dito sa sodium-potassium ATPase na to, ibablock niya yung paglabas ng sodium. Therefore, magkakaroon ka ng mataas na level ng potassium extracellularly if ever man na mapatagal ang effect ng digoxin dahil nga sa decreased metabolism nito, magkakaroon ka ngayon ng hyperkalemia kasi nga hindi lalabas talaga si digoxin kasi nga patuloy yung effect ni digoxin sa sodium-potassium ATPase. So that's for hyperkalemia. Now, we are going to move on with the negative inotropy. Dito naman sa katabi ng sodium-potassium ATPase pump, is si sodium and calcium exchanger. Ano naman sa normal physiology ang nangyayari dito? Sa sodium potassium exchanger, si sodium dapat papasok siya intracellularly. Now, pag pumasok si sodium intracellularly, supposedly dapat lalabas si calcium palabas for its action na magkaroon ng force of contraction. Kasi kapag lumabas si calcium extracellularly, dun pa lang siya magkukos ng inotropy. Ano ba ang inotropy? Force of contraction. So ito yung ang calcium ang or ang nagkukos ng contraction ng heart natin. So kapag naman na-block ang pagpasok ni sodium sa sodium exchanger, since di ba nga ang digoxin hindi niya napalalabasin tong si sodium, so walang lalabas na sodium, therefore wala din papasok na sodium. Now ang mangyayari, wala din lalabas na calcium, so definitely magkakaroon ka ng negative inotropy or bababa ang force of contraction mo. Okay, so next, antibiotics plus anticoagulants. Antibiotic kills bacteria in the GI flora. Alam naman natin, like for example, yung erythromycin, di ba? Kapag uminom ka ng antibiotic, technically mamamatay yung mga bacteria sa ating GI tract. So it will interfere with the vitamin K production of the microorganism. Ang mga bacteria kasi natin sa GI tract, they are producing vitamin K. Now, if uminom ka ng antibiotics, together with the anticoagulants, it will enhance the anticoagulant effect of the anticoagulants. Like for example, warfarin, Pradaxa, yung mga ganyan na anticoagulants natin. Kasi nga, wala na magme-metabolize sa kanila and wala na ring vitamin K. Ang vitamin K kasi is procoagulant. So sila yung nagre-regulate ng concentration ng ating anticoagulants. So meaning, kapag hindi sila na-regulate, mag-enhance ang ating anticoagulant effect. It will also increase in bleeding tendency sa patient natin. Next, oral contraceptives plus antibiotics. As we all know, microorganisms are needed to activate oral contraceptives. So kapag namatay na yung mga microorganisms sa katawan natin, wala nang mag-activate sa oral contraceptives natin. Now, kapag hindi na-activate ang ating oral contraceptives, anong mangyayari? Magkakaroon ng decreased effect on the oral contraceptives. So, kung ikaw, kunwari, uminom ka ng lady pills, tapos uminom ka rin at the same time ng antibiotic, so kung ikaw ay nagpe-prevent ka ng pregnancy, then it will cause you to have an increased chances to be pregnant kasi nga, wala na yung mag-activate dun sa oral contraceptives mo. So, what are you going to advise those patients buying oral contraceptives, especially when you are in the community pharmacy? Always take a look if you are going to drink this with antibiotic. Better to have a dosing interval with 2 to 3 hours also. And that is going to be the last part of our alteration of GI flora. Let us move on with the malabsorption caused by the drug. Methotrexate and neomycin. Neomycin causes malabsorption in the GI tract. This is going to impair the absorption of drugs, including methotrexate and digoxin. So neomycin is going to impair the absorption of methotrexate and digoxin. So alam naman natin na kapag hindi na-absorb si digoxin or hindi na-metabolize si digoxin or hindi rin ma-absorb si methotrexate, mataas ang chances na hindi sila mag-i-effect. So another dispensing or medication counseling nyo guidelines to your patient is to have a dosing interval. Well, normally naman sa mga pharmacokinetic interactions natin, wala naman tayong ibang i-advise sa mga patients natin kung hindi ang dosing interval of 2 to 3 hours. As long as alam nyo kung ano yung i-interact ng ating mga drugs, then you are going to be confident na dapat magkaroon sila ng interval. So that's it for our our lesson for today. I hope to see you more in the next video, and thank you for your attention.